This is part 2 of an introduction to a low FODMAP diet. This presentation will include application as well as implementation. A quick review of a low FODMAP diet before we get started. It is a temporary elimination of fermentable oligo, di, and monosaccharides and polyols. These are short-chain carbohydrates that are considered FODMAPs due to their high osmotic activity, rapid fermentation, and poor absorption in the body. It involves reducing the consumption of FODMAPs until symptoms significantly subside and then gradually reintroducing FODMAPs. Individuals must be followed for tolerance, and a multidisciplinary approach is required in order to individualize the reintroduction phase. Prior to implementation, the individual should be assessed. A 24-hour diet recall should be conducted in order to gain perspective on the amount and frequency of FODMAPs in the current diet. It's also important to get an idea of their meal patterns, types of foods they are consuming, and if they're taking any supplements. Sometimes supplements can contain high FODMAP ingredients, for example, chicory root or inulin. The patient should also report any known foods that already are known to cause GI distress. The amount of caffeine and fat in the diet should also be evaluated, since these can be common GI irritants. The patient should be referred to a registered dietitian for education, implementation of the reintroduction phase, as well as monitoring and evaluation of the entire process. The patient should trial a low FODMAP diet to see if they experience a significant reduction in symptoms for about 2 to 6 weeks. It's important to have the patient keep a food log and food and symptom diary or journal throughout the process in order to correlate specific foods with GI distress. If there is no resolution in symptoms during this time, this may signify further restriction of FODMAPs is needed or further evaluation of the patient's diet is necessary. As found in the research discussed in presentation 1, not all participants will respond to a low FODMAP diet. The reintroduction of FODMAPs is highly individualized. This phase will help to identify personal triggers and facilitate expansion of the patient's diet. The patient should continue with the food and symptom diary or journal, especially during the reintroduction phase. A small portion of food from one category should be reintroduced once daily for 3 days, and the patient should monitor and record any symptoms. If symptoms occur, the patient should return to a low FODMAP diet until symptoms resolve. If patient experiences no symptoms, they can re-challenge by introducing a different food from the same FODMAP category or move on to a different category. Re-challenging the same category will ensure that this category is not a trigger. This decision may be personal preference and also preference based on the dietitian. This is an example of a reintroduction schedule. The patient should be aware that some FODMAP foods fall into more than one category, and that these foods should not be used during the reintroduction phase due to the inability to correlate symptoms with specific categories. So we see here for the first 3 days we are introducing garlic, which is considered an oligosaccharide. So if the patient were to experience no symptoms, they would move on to Sunday through Tuesday, the next 3-day cycle, and introduce a different FODMAP category. For example, this one says dried apricots, and those are considered polyols. So after trying those apricots, if the patient were to experience symptoms after that Tuesday, they would return back to a low FODMAP diet until symptoms subsided. Throughout the elimination and reintroduction phase, patients' nutritional and health status should be monitored. The food and symptom diary will evaluate adherence to the diet, as well as a 24-hour food recall. Any GI distress should be evaluated, as well as changes in weight and height. Labs should be monitored for any nutritional deficiencies, especially if the elimination phase is prolonged due to GI distress during the reintroduction. A low FODMAP diet is not a complete elimination of all FODMAPs. It involves limiting portion sizes and reducing the amount of foods that are considered high in FODMAPs. Ongoing elimination of foods that do not impact GI symptoms will result in altered nutritional status. The goals of a low FODMAP diet include limiting one FODMAP-friendly fruit at each meal, avoiding any foods that are already known to cause GI distress, ensuring nutritional adequacy throughout all phases of the diet, and to normalize eating patterns and ensure that there's variety in the diet. Explaining a low FODMAP diet can be overwhelming to a pediatric population and their parents. It's important that they understand that there are certain categories of carbohydrates that have been found to cause GI irritation, and that the reduction of these carbohydrates in the diet could help to improve symptoms of IBS. It's also important to convey that these carbohydrates are not the cause of IBS. Assure the patient and parents that there are still plenty of foods that they can have that will temporarily make up an adequate diet for their child. Encourage them to meet with a pediatric dietitian or a dietitian that specializes in low FODMAP diets for proper education and individualization of the diet. This chart lists foods that are high in specific FODMAP categories. These foods should be temporarily eliminated from the diet. Take note of some of the foods that fall into more than one category on this chart, specifically in the fruit and vegetable categories. So now that we have talked about foods that we should reduce or eliminate in the diet, we also want to talk about what foods the patient can have during the reduction of FODMAPs. This slide provides some examples from each food group. All animal proteins, you may notice, are low in FODMAPs. Nuts, for the exception of cashews and pistachios, along with their associated nut butters, are acceptable as well. Gluten and wheat-free grains are also low in FODMAP content. And as for aged cheeses, a good rule of thumb is to read the food label to check for any food additives or fillers. You can check the ingredients list and also look for the sugar content on the nutrition facts label. If the sugar content of hard cheeses is anything greater than 0 grams, it may cause some GI distress. But again, this is individualized and will vary from person to person. And this is an additional chart listing foods that are low in FODMAPs. It's important that patients and their families are able to properly read food labels and be able to identify high FODMAP food ingredients in the ingredients list. This chart shows a list of common FODMAP ingredients that would be found on ingredients list of foods. So some common ones, of course, would be fructose, high fructose corn syrup, honey, It's also important to provide resources to patients and their families. So this slide provides a few resources that suggest low FODMAP recipes and sample meal plans. Those charts from a few slides ago are also from this link here. Apps may also be helpful for grocery shopping. The Monash University app was shown in the brief video during the first presentation. However, this app may be costly for some. So an alternate free option is the Shopwell app. Shopwell allows the user to plug in their dietary restrictions, and then the user can scan the barcodes of food items, and the app will alert the user if the item is okay per those dietary restrictions. And if it's not, the app will give alternate options as well. Implementing an elimination diet, even when temporary, has several limitations in the pediatric population. This is a strict elimination diet. Restrictive diets may eliminate staple foods from a child's diet, which will be difficult, especially among picky eaters, to find alternate options. Another limitation to consider is the impact of elimination diet on growth. Since this is temporary, 2 to 6 week elimination diet, growth should not be affected. However, ongoing or prolonged elimination, particularly of sources of vitamin D and calcium, should be closely monitored. Restrictive diets can also lead to weight loss, fear of eating, nutritional deficiencies, and the development of disordered eating and eating disorders. This diet also restricts 2 prebiotics that we spoke about that fall into the oligosaccharides category, which are inulin and fructooligosaccharides. The possibility of bacterial overgrowth should be considered, as this may initiate an inflammatory response and counteract the diet. Supplementation and the use of fortified products may also be necessary based on outcomes of FODMAP tolerances or intolerances for long term. A few nutrients of concern are the B vitamins, iron, protein, folate, and fiber, which would come from the reduction or elimination of wheat, barley, and rye. And then also vitamin D, calcium, and protein from the reduction or removal of cow's milk from the diet. And then, of course, for cultural considerations, this does restrict legumes and lentils, so for vegan and vegetarian diets. A registered dietitian is crucial for proper diet education and implementation in order to prevent nutritional deficiencies, prevent stunting of growth, and to aid in the development or continuation of healthy eating patterns. A low FODMAP diet is also highly individualized. An RD will be able to work with the patient and their family to develop an ongoing tailored plan for the reintroduction of FODMAPs. This concludes the 2-part series for an introduction to low FODMAP diets and the pediatric population. If you would like to pause the video for a moment and test your knowledge, you may do so. Answers will be provided on the next slide, and additional information along with the links and resources will be posted in the description box below.